Welcome back, everyone, to the ID and Dementia Texas Project ECHO. It is May, and if it's May, it means Dr. Lucy Ezralou is our presenter. We're going to talk about trauma-informed care. We will have other members of the hub team joining us. Dr. Keller is actually in Spain, in Barcelona, attending the International Conference on Alzheimer's disease and Parkinson's disease. So he won't be with us today. Kathy Bishop will be joining us shortly. Kathy and I are actually in Texas conducting one of our 3-day workshops. So she'll be in with us in just a little bit. Bonnet Fay is on vacation, and we're waiting on June Sadowski and Cameron Jeter, who hopefully will be joining us very soon. But in the interim, the key folks of us are here, Lucy Ezralou and I. And so without further ado, I will just say a couple of quick housekeeping things, which please put your questions in the Q&A box, and you can put them in there at any point and we'll monitor them. And if you have sort of technical kinds of questions, you can put those in the chat box. If you would just in the chat box now, put your name and your organization so we know who is with us. And this is being recorded, and the recording will be sent out to everyone. We have about a little over 100 people registered for this, but of course, work schedules are such that we understand not everyone is available to attend live, but everyone does get the recording after the fact. So that's why we don't always have a whole lot of people on here live with us, but we do have people who will watch the recording, and we have a lot of folks who watch it after the fact. So that's just the reality of work life. So with that, I am going to pass the baton over to you, Dr. Ezralou, and we will go from there.
And let's see if we can get this where it needs to be. Okay. So, hi everybody. So, as Kathy indicated, I'm Lucy Ezralou. In addition to being a member of the UTH ECHO Hub, I have other affiliations that I want to just lift up for you. One is that I'm a board member of the National Task Group. The other is that I co-chair with Kathy Service the NTG's Applied Research and Clinical Health Panel, which we call ARCH. I am a senior psychologist supervisor for the California Department of Developmental Services, and I have just recently joined the board of UCP Oregon. So I'm glad to lift up these affiliations. And today we're going to pay attention to behavior as it might relate to trauma or trauma exposure among individuals, adults with intellectual disabilities. So having said that, let's think about what our objectives are for today. The objectives for today is to recognize when trauma experience may drive observed behaviors of concern. And for that, I'm going to be using two kind of models or frameworks. One is the 4 R's of trauma-informed approach, and the other is 6 principles of trauma-informed care, which I'm also going to apply to a case illustration involving a consumer and systems that support him. So that's what I'm hoping to accomplish with you this morning, and I'm glad to be able to do that. So before we kind of dive into it, I think it's worth talking about what trauma is. So trauma is an emotional response to a stressful or disturbing event or events that can have lasting negative effects on the individual. So it can involve a single exposure to an extreme stressor, or it could be a series of events that happen, either within a short period of time or over a series of years. And as a result, the individual experiences physical and emotional, or perceives themselves to be physically or emotionally in harm's way or threatened. And, certainly I don't have here the definitive list of all the ways in which an individual may experience traumatic, episodes or events. But among the things we commonly think about are accidents like motor vehicle accidents, natural disasters like floods, earthquake, wildfires, witnessing or experiencing violence. So it is the case that, certainly if you're the victim of violence, that could be a traumatic exposure, or you could witness somebody who is the victim of violence. If you have a life-threatening illness and all the procedures that might be involved with that, childhood abuse or neglect, bullying, being the victim of bullying or victim of domestic violence. The loss of a loved one might be a traumatic experience for somebody. Surgery or medical procedures. And so again, this is not the definitive list, but it gives you the idea of among the things we think of as extreme stressors. So I want you to notice two things about the definition of trauma that I just shared with you. So, very commonly, people will talk about events as being traumatic, but actually, it's not the event itself that's traumatic. It is the person's reaction to the event. Okay, so yeah, many bad things happen. There are adverse events that any of us and all of us have experienced at one point or another. That does not necessarily mean that we've had a traumatic reaction to it or that it constitutes a trauma exposure. And it certainly doesn't mean that if bad things happen to you, that you will develop post-traumatic stress disorder. It is whether the person exposed to a trauma is, in fact, perceiving themselves as being threatened, either bodily or emotionally. They believe that they're in harm's way or that their life was in some way endangered, serious injury, or the risk of death. So whether or not any person perceives any event as a traumatic experience is for that person to decide. It's not for others to decide, oh, that wasn't really that bad an event, or why are they having that kind of reaction when it didn't seem to be that stressful. It really is all, in a sense, in the eye of the beholder when we talk about traumatic exposures. So, of course, we can't talk about trauma or think about trauma unless we give attention to ACEs. You probably all have heard about ACEs, so this is just meant to be a quick overview. Certainly, there's much material online if you want to dive deeper into it. So this was the result of a study that was conducted by Kaiser Permanente in California, in which they were curious about the longer term outcomes of early childhood adverse experiences. And so since that time, we have come to understand that there are a list of situations that if you're exposed to in childhood, you are likely to have negative health outcomes, both physical health, emotional health, and social health outcomes. So these are a series of experiences that, occur during childhood, typically before the age of 18, and have lasting, significant negative impact. So that includes, of course, physical and sexual abuse, emotional abuse, neglect, both physical and emotional neglect, witnessing domestic violence, substance abuse in the household, into a family member who is mentally ill, particularly if that mental illness is not well managed or controlled, parental separation or divorce, and incarceration of a household member were among the childhood adverse experiences that were just lifted up for our attention as having longer term consequences. Any of us might have experienced any of these things on this list, and certainly the people whom we support may have experienced some of these conditions or situations earlier in their lives that are on this list. So the point is, even though ACEs is a well-known study having to do with events that occur that somebody exposed to early in life, the fact of the matter is a traumatic exposure can occur at any age. So accidents, medical procedures, and hospitalizations. In the case of people whom we support, some of them have an extensive history of institutionalization, particularly if they are older, domestic violence, neglect, physical or sexual abuse, and exposure to natural disasters, wildfires, floods, earthquakes. I know in California, wildfires are a very big concern. And in the area in which I worked at a regional center, several years ago, they had experienced wildfires and devastating wildfires 5 summers in a row, and led to displacement of individuals from their group homes and a lot of mayhem. So that certainly constituted, traumatic exposure for some of the individuals whom we supported in the region at that time. So what are some of the long-lasting effects of early trauma exposure or actually adult trauma experiences? Because we know that these actually impact the brain. So for children, early exposure can mean that it influences the brain chemistry, and it can affect in terms of even adulthood, brain and body functioning, leading to increased risk of chronic diseases such as heart disease, stroke, cancer, and diabetes. Certainly, it has been associated with mental health problems such as depression, anxiety, and PTSD. It's been associated with increased risk for substance use disorders for children and for adults. It has been linked to poor academic or vocational performance. It impacts upon social relationships, and there's an increased risk of exhibiting behaviors of concern. So one of the things that we're thinking about in today's session is how might behaviors of concern like aggression, self-injury, elopement, property destruction, things like that, that we, or maybe sexually disinhibited behaviors that we consider behaviors of concern, in what way may they be linked or tied to earlier traumatic exposures of the individual? There's also been a link to increased risk of violence and criminal behavior and increased risk of dementia as one ages with disabilities. Now, I'd have to say that in the last point, there has been in the literature a clearer link between early exposure or earlier adult exposure to traumatic experiences and dementia. For instance, there have been studies of veterans who were combat veterans earlier in their adulthood. And that appears to have been related not only to the incidence of PTSD, but to the onset of dementia in some of these individuals. We have less robust literature that links that to individuals with disabilities, although, clinically, we have no reason to doubt that there is a connection there. So we have ACEs, but we also have what's called PACEs. That I'm not as sure that you've been exposed to before. Those are the protective and compensatory experiences. So what might serve as buffers? What might help resilience in individuals? So they are the positive childhood experiences, and I would maintain the positive experiences that may occur for people as they get older that foster resilience and well-being. They act as buffers against the negative impacts of adverse childhood experiences. And I'm going to extend it to say for our population, for experiences people may have had in their earlier adulthood, and promote healthy development. And they include strong relationships, supportive environments, and opportunities for learning and engagement. We'll have more to say about this later as we get into this notion of trauma-informed care. So let's look at some of the relationship-based resources that go along with these protective and compensatory experiences. So unconditional love involves feeling safe, loved, and cared for, regardless of the circumstances, from a parent, a caregiver, a partner. Having a best friend, at least one strong friendship which provides support, companionship, and a sense of belonging for the person. Volunteering or helping others, engaging in community service, which can foster empathy, responsibility, and a sense of purpose. Being part of a social group, participation in clubs, sports, or other social activities which promote social skills, teamwork, and a sense of community. And having one mentor or somebody who is older, wiser, can provide some guidance outside of the family, a positive adult role model that can provide guidance, support, and encouragement. Then what are some of the resources that resource-based protective and compensatory experiences? Well, it's having your basic needs met that provides a foundation for healthy development, living in a clean, safe home with enough food, having resources and opportunities to learn, such as access to education, skills training, and learning resources. It's crucial for future success. And I don't know about you, but as I'm kind of reviewing this with you, I'm thinking about a number of consumers whom I've worked with who did not have those resource-based paces in their lives, either as children or as young adults. Engaging in hobbies or creative pursuits, participating in activities like sports, arts, or music, which can promote mental and physical well-being. Again, not sure that people we support have that kind of access to these kinds of activities that can promote well-being. And having routines and fair rules at home, clear expectations, and consistent discipline, which actually creates a sense of security and structure for the individual. So what is trauma-informed care? I mean, we use that term quite a lot in healthcare field, in human services field, but what does it actually entail? So I took the liberty of taking, this is from the Texas Health and Human Services website, their description. So it is certainly pertinent to all of you on the call today in terms of what's trauma-informed care as envisioned by Texas HHS. So trauma-informed care is an organizational structure and treatment framework for understanding, recognizing, and responding to all types of trauma. It focuses on physical, psychological, and emotional safety and helps survivors of trauma, that is, rebuild a sense of control and empowerment. So we'll have occasion to kind of look at that a little bit more as we go through. So trauma-informed care. Trauma-informed care is an approach that recognizes the impact of trauma on the individual. So now we've moved from the Texas HHS website definition, and now I'm sharing with you what we in the field kind of commonly look at as constituting trauma-informed care. This approach is used in various settings that emphasize the importance of recognizing and responding to the impact of trauma. So instead of asking, what's wrong with you? A trauma-informed care approach involves asking, what happened to you? Because understanding what happened to the individual helps us understand why they may be engaging in some of the more challenging behaviors or having difficulties in the present moment. And recognizing that it's really important to have a complete picture of a person's life situation, both past and present, to provide effective care. We really need to know the person's life story. So trauma-informed care integrates knowledge about trauma into the kind of policies, practices, and procedures that we can develop that create environments that are safe, supportive, and empowering for everyone, the individual consumer, their family, and the staff who are involved in supporting that individual. Trauma-informed care is about providing supportive environments that acknowledge the impact of trauma. So we talk about the 4 R's of the trauma-informed approach. We talk about the R of realize, the R of recognize, R of respond, and R of resist. And by realize, we mean realize the widespread impact of trauma and understand potential paths for recovery. R for recognize the signs and symptoms of trauma in clients, families, staff, and others involved within the system. Because what we're saying here is trauma-informed approach is a systems approach. It's not just a therapeutic intervention with an individual who may have experienced trauma. It is involving everyone who kind of touches that individual by providing support. R for respond by fully integrating that knowledge in order to develop policies, procedures, and practices. And what we are resisting is re-traumatizing. And this model was taken from the Child Trauma Stress and Trauma Network, how the National Child and Stress Trauma Network, but definitely we could say the same thing about our support of adults with intellectual and developmental disorders, that we want to resist the re-traumatizing them. And I'll have more to say about that in a few minutes. So realizing is the first step, and realizing that trauma affects people in many different ways. It can affect someone's physical health, mental health, and overall behavior. You know, I remember, and this does not have to do with intellectual and developmental disorder, but years ago, I did my pre-doctoral psychology internship at a VA medical center. And they had a nursing home component to it. I worked in that, was one of my rotations. And I met a gentleman in his 80s who had served in the war, World War II, at that time. 80s would have put him as a fairly young man during World War II. And, and he had a very difficult combat experience, but seemed to navigate that very well. He, went on to have a very successful career and a very vibrant life and seemed to put it well behind him. And then he, in his early 80s, got mugged. And as a result, he was pushed down, he broke a hip. And so that traumatic experience of injury as a result of a mugging really threw him back to when he was a combat, soldier. I mean, here, decades later, he was thrown back to this experience. So this is not something that he obviously felt in his life as having an immediate consequence. He thought everything had been negotiated well. but here he was later on with this basically being reactivated. So why am I saying that? Is because trauma can have not only immediate or proximate effects, it can have distal or distant effects on the person's life. So if we recognize that trauma is a complex experience, it helps us create environments that acknowledge the widespread effects of trauma and the needs for comprehensive care. We recognize signs and symptoms of trauma by being aware of physical, emotional, and behavior indicators. And that I think is particularly important for our population where individuals may not have the language skills to communicate how they are feeling physically or emotionally and may demonstrate disturbance and upset via behavior and behavior changes. Recognize that individuals with IDD are at a higher risk for abuse and neglect, often from caregivers, and recognize that these signs, which are often behavioral, we can provide right support and intervention, ensuring that everyone receives the care they need. Terms of responding, it's like once we understand what's going on for a particular individual and we have a trauma-informed care focus, we're in a much better position to incorporate this in our policies, procedures, and practices and help people feel safe and respected. And a lot of it has to do with how staff is attuned to, and family members, I would say too, with sensitivity and care ensuring that response to trauma and the behaviors that may be related to it is a compassionate and informed response. And what I said before about resisting re-traumatization, we want to actively avoid situations that might trigger traumatic memories or experiences. By creating secure, supportive environments, we help people. So it's important to understand what might trigger a person, what might be re-traumatizing, and take steps to prevent it. For instance, in the developmental center, when I worked in a developmental center, we really did not have this idea in terms of use of restraints. We used restraints then uh, and we're talking about last century, but the end of in the 1990s, but we did not, really even consider whether or not the individual had had a difficult experiences for which being restrained might be re-traumatizing. So I said there were 4 R's of a trauma approach, and there are 6 principles of trauma-informed care: safety, trustworthiness, and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, cultural, historical, and gender issues, or what we may just kind of sum up as having humility. So creating a safe space. Okay, this includes physical safety, emotional support, and fostering healthy relationships. And it may involve teaching individuals to establish and communicate about what is safe social boundaries for them. For instance, there was a while I was working with some children with intellectual developmental who had come through the child welfare system and had had some, traumatizing experiences. And it was very important because they did not have good boundaries in terms of physical boundaries or emotional boundaries. And we used to do a thing called Space Camp, in which we talked about what are healthy spaces. And if any of you use the old Circles program, that's another way to talk about what are safe spaces, social spaces, and how to develop them. So what goes into creating safe spaces? Just the ability to be able to talk with family or staff about feelings can change outcomes. When a person feels supported during difficult times, enjoying community traditions, feeling a sense of belonging in high school, in school, at work, in the community, having supportive friends, Feeling safe and protected by somebody in one's home is also crucial because it encourages friendship and peer interactions. You notice a lot of this is taken with a child focus, but I want you to also extend it to the adult individuals whom you support. So part of feeling safe is being adequately equipped with coping skills, so you're less easily overwhelmed by challenging situations. So educate children and adults on skills that promote positive interaction, resilience, respect, civility, and compassion. Help consumers understand at an age appropriate and at a developmental appropriate level what adversity looks like, where it comes from, and how it can be overcome, involving having the tools to cope and the compassion to support others. So another part of what a principle, along with safety, is building trust and transparency. So what helps to build trusting relationships? Clear communication about expectations, honesty, there's transparency as it relates to the person supported, reliability, showing that the consumer can count on you. Don't make promises you can't keep or are not yours to make. When you say you're going to show up, show up. When you say you're going to deliver on something, deliver. If something comes up and you can't deliver on something promised, be clear to involve the consumer so they understand why it is that you're not going to be able to follow through on something promised. Consistent boundaries help build trusting relationships. And one of the biggest things that happens when somebody has a traumatic experience is that they lose trust in other people to protect them, in other people to work with them, and they lose trust and confidence in themselves. So, empowerment and choice. Trauma survivors often feel powerless. So, giving them a voice in their treatment, such as if they're able to indicate their preference for treatment approach or what their personal goals are, helps them feel more engaged and invested in their recovery and restores a sense of control to them. Collaboration and mutuality, emphasize partnership and care through which service providers, family members, service recipients have input in the development of treatment goals and strategies. And collaborative approaches engage individuals with IDD in their care planning and decision-making processes, even if it's just to elicit from them what their preferences are. Can they talk about what their needs are? Can they choose between two possible options for their daily support? This empowers individuals, acknowledges their autonomy, and that is essential for building trust and support. Peer support, utilizing peer support through day programs, activity centers, or group therapy can help consumers feel less isolated. So one of the things that can happen is that if you've had a traumatic experience, that can be an extremely isolating situation for you. You might come to believe no one's going to understand you, no one's going to believe you, no one could possibly see things from how your experiences because no one else has probably gone through what you went through. But having peer support can be extremely helpful to people. Knowing that others have had similar struggles can foster a sense of being validated and is essential for the person to heal. The humility acknowledges cultural, historic, and gender issues that may have contributed to vulnerability to abuse, neglect, and adverse experiences. So we know certain groups have been more targeted for just adverse events. And certainly the people whom we support with intellectual and developmental disorders and disabilities, they are a vulnerable group And there are much higher rates of neglect and abuse for our population than for other groups. Understanding trauma recognize that individuals with IDD may have experienced various forms, including abuse, neglect, medical procedures, institutionalization, and understanding the prevalence and impact of trauma is crucial for effective care. They may have also experienced microaggressions, not necessarily bumping to these kind of extreme stressors, but on a daily basis or a regular basis, feeling humiliated, being bullied, having their disability kind of used against them in various ways. And in some cases, adverse experiences have been intergenerational. It's not only that our consumers have experienced it, but their parents or family members and generations, preceding them. One of the best things that we can do is to provide training. All family and staff, including administrative staff, supervisors, managers, direct support professionals, should receive training on trauma and trauma-informed principles, even if they are not going to be working directly with the individual, but may have more of an administrative or support role, clerical, they're in the office, whatever, at the day program or for group home agency. It's really important that everyone understand these principles. And to the extent feasible, self-advocates should have an opportunity to learn about trauma from both a psychoeducational as well as a therapeutic perspective. It helps staff recognize trauma responses, particularly if they are behavioral in form, and get the sense that, there is a reason for these behaviors that may be linked to the kinds of experiences that people have previously had. It helps with the identification and implementation of support strategies. Very important that self-care is for everyone. It's for self-advocates, the consumers we support, staff, and family. And we should be looking at providing resources for self-care and wellness for our consumers, for their families, and for direct support staff. Overstressed families and staff can contribute to a negative environment unwittingly. So supporting their well-being can help prevent burnout and improve the quality of care, as well as help with retention and improve the quality of the staff experience. And then we want to, understand, I am a big advocate of ABA. And I think that there is absolutely a way to conduct functional analyses or assessments that incorporate a knowledge of trauma-informed care. We certainly want to step up the use of positive behavior supports, which is kind of a first cousin of ABA, in which we're looking at ways to enhance the person's environment. And we want to understand that underlying factors that drive behavior and the function that's being served. What is the individual communicating to others through this behavior? What are the person's unmet needs? And incorporate trauma-informed principles into behavior support strategies and move away from punitive measures towards compassionate and effective interventions. And of course, we have to be involved in continuous evaluation and improvement. So teams and organizations should regularly assess their trauma-informed care practices and make necessary adjustments to improve care and support individuals with IDD. So I want to give you a case scenario of Jeff. This is somebody that I worked with for a while. And I worked with him, I worked with his family, I worked with the staff that supported him. And he's a 58-year-old male with a history of post-traumatic stress disorder. In fact, I'm the one who diagnosed him with PTSD. He has mild intellectual disability and Cornelia de Lange syndrome. So just a little bit about Jeff. Jeff's parents divorced when he was a teenager. He grew up in an apartment with his mother and younger sister. he had a life, and he had a really good life going. He worked at a local supermarket and he enjoyed it. He had friends, he had a girlfriend. He would travel independently using buses and trains. He was really proficient at it. He gained proficiency in karate, was well liked by neighbors and coworkers. He would help his family out by cooking, shopping, assisting with household chores. And as I said, in other words, he had a life. And it was going pretty well until about his mid-20s. Uh, it is not clear if this was the particular trigger for his behavioral changes, but he became emotionally and physically dysregulated shortly after being rejected by his girlfriend. This is a girlfriend that he had from high school. They'd been together for several years, and she basically just dumped him. And shortly thereafter, the family noticed that there were changes. But, increasingly, there were changes. And he eventually attacked his mother and set a garbage pail full of paper on fire in their apartment. This was not a behavior that he had previously engaged in. It was the first time that, as the mother and sister were observing increasing changes with him, this is the first time it had bumped to a level of being potentially dangerous or difficult. So he was hospitalized. This was the advice of his physician. He was hospitalized on an acute inpatient psychiatric unit at the time. However, they didn't find that, he was stabilizing. They did not think he was safe enough to be discharged back to the community. So he was referred to a state psychiatric hospital. So this is where his institutional career began. So from the state hospital, he was sent to a developmental center where he actually resided for 22 years. So things really rapidly or seemingly rapidly went off track for Jeff. And I should kind of give you the postscript, which he was deinstitutionalized at the point when the developmental center was closing down and was sent to a group home where he's been living for the past 10 years. So know that that's happening and he's gotten beyond that. However, this was really a major shift in his life. While in the developmental center, he was repeatedly sexually and physically assaulted by a peer. When he attempted to engage staff to tell them, report this, they did not believe him, they ignored him, and they certainly did nothing to protect him. So he went from kind of using what he thought was the, channels that he should go through in order to get help. And finding that that didn't do anything for him, he started setting fires on his unit at the developmental center, engaged in disruptive behavior, never really injured anybody, but it was enough to get him in trouble and brand him a behavioral problem. So he got moved to a single room. Interesting how you can get rewarded in that way. But the important thing is that he was away from the perpetrator who was harming him, which was his main goal in engaging in this. He wanted to get away, and there was no other way he could think of getting away. On one occasion, he was approached by a female staff member whom Jeff found or experienced as menacing, and it's not clear to me exactly why. He told her not to come near, but she ignored him. She proceeded anyway, and he slapped her. She was not hurt, but she pressed charges against him. So now we've gone from Jeff in the community to in a psychiatric unit to in a state hospital to in a developmental center, and in terms of now he has legal involvement. So he was seen just generally as a bad behavioral problem. When his mother and guardian protested, the DC tried to shut them down by claiming the mother was meddling and interfering with the operation of the facility. So some things I want you to know about Jeff, and I think is an important tip in terms of understanding our work with individuals who are complex, who have developmental disorders as well as other things going on. So he has Cornelia de Lange syndrome, which is a rare genetic disorder. It affects multiple body systems, leading to a range of physical, intellectual, and behavioral differences. And it's characterized by growth delays. Indeed, Jeff was very short in stature, distinctive facial features, and potential issues with limbs, heart, and other organs. So both prenatal and postnatal growth issues, intellectual disability. Now, he probably placed in the upper range of the mild intellectually disabled range. He actually, I thought, was quite capable on many levels, at least at the beginning. There are very distinctive facial features associated with Cornelia de Lange, highly arched eyebrows, long eyelashes, long set ears, small and widely spaced teeth, and a small upturned nose. There can be malformation of hands and arms. That was not the case for him. And then behavioral issues are noted to be more common with CDLS. Many people exhibit autistic-like features, such as repetitive behaviors and difficulty with social interaction. That was not initially the case for him, but I think you'll see that he did develop some issues over time. But I don't think it was really linked to autistic-like features. And he was hyperactive and certainly had anxiety in his history, and certainly with these traumatic exposures, that was fulminating. Other potential problems: GERD, has GERD, no seizures, no known heart defects or hearing or vision problems at this point in time. So one of the big things is you need to know the person's life story. So this is just kind of an example of an institution. So the family was encouraged to put together a photo album of Jeff's life leading up to his hospitalization in his 20s. And Jeff's mother and sister sat with Jeff to write his story. The staff was encouraged to do a chart review and come up with a timeline of events for Jeff, which was updated by Jeff and his family. In other words, he reviewed it. The staff pulled it together, he reviewed it, he gave his consent or said, no, that's not kind of what was going on for me. But it was a very good collaborative process in developing a life story so people know who Jeff is. Jeff went from his home environment in which he was encouraged to communicate his needs and preferences to an institutional setting where no one listened to him and no one believed him. So he went from an experience of being validated and valued to being invalidated. And the only way he could think of to protect himself was by acting out so that he would be removed from direct path of the person victimizing him. Jeff learned it was better not to speak up. He fared better with staff if he just didn't complain and kind of kept to himself. And he was in a setting that was invalidating for him for 22 years. So by the way, tip number 3 is listen to people, what they tell you, what their experiences are. Tip number 4 is the trauma-informed care works best when everyone is using it. This includes the family members and staff, and to the extent possible includes the consumer. So actually, I did develop a little psychoeducational curriculum for Jeff and for the family and for staff. So each at their level, people could understand how his previous life experiences were impacting upon the behaviors of concern that he had exhibited. So training, training, and more training. The staff at the DC did not respond, acknowledge, or, they didn't recognize, acknowledge, or respond to signs of his traumatization. He was traumatized by repeated victimization by a peer. And so also traumatized by the staff's response because he was being invalidated. Now, Jeff's current staff need to be aware of the impact of previous traumatic experiences, what can trigger him. One of the things that he does is when very upset and triggered, he will now shut down and hole himself up in his room. And from the staff perspective, it was like, well, he's not, saying anything and he's not creating any problems, so there's no issue here. However, he then would ignore his hygiene and he would be irregular in his participation in meals and would not do church. So, they had to understand that, that was his way of communicating that something was wrong. And in fact, we have to be aware of history so we don't re-traumatize. Unfortunately, one of his first housemates happened to be from the same developmental center as Jeff. Now, he was not the person who victimized or was the perpetrator with Jeff. However, he was a big person who physically reminded uh, Jeff of the perpetrator, and he came from the same facility. So that there were many instances where he was just triggered by the presence of this individual. So staff need training in trauma. The role of Jeff or any particular consumer's neurodevelopmental disorder, in Jeff's case is Cornelia de Lange syndrome, and the role of individual life experiences. And in Jeff's case, it was, what happened before and during institutionalization to understand current behavior. And then the team needs to continuously monitor what works and doesn't work, and in a real-time way, make adjustments to recalibrate their approach as necessary. There's no such thing as, and I have seen this, having a behavior plan which is the same behavior plan that's just continued year in and year out, and there's been no progress and there's really been no attention to, is this effective? Is this working or not? And we talked about the importance of self-care. So, I mean, promoting self-care for everyone. So we did work on this with family, with Jeff, and with his staff about how do you set healthy boundaries? How do you tell people if they're getting too close to you? That kind of thing. Emotional intelligent awareness by giving him, we did an incredible 5-point scale, managing stress and raising resiliency, working on breathing and other stress management techniques, self-care plan and tools. Um, he was not a journaler, although he could read, and he reads and writes in a very elementary fashion. He's not somebody who's going to be journaling, but that is certainly something that can be used. And breathing exercises, we did quite a lot and were very helpful to him, the family, and the staff. So how did we do in promoting the 4 Rs and the 6 principles of trauma-informed care? Well, we engaged in intensive training on Cornelia de Lange syndrome and trauma as it had impacted Jeff. And this is, I have to say, in my years of working in the field, I find this to be often missing. And even for people who are not trauma exposed, but behavior plans or interventions that are developed without being cognizant of how the person's unique behavior phenotype having to do or what may be characteristic of a particular neurodevelopmental disorder, how that impacts. I mean, for Jeff, he is more prone to anxiety. He is more prone to self-isolate, he is more prone to a lot of things having to do with his Cornelia de Lange syndrome. And that needs to be factored in this equation. The other thing that needs to be factored in is that, for instance, one would not use something like restraints with him ever. Not that the group home is able to use restraints, but they have to be also very aware of how, when Jeff is shutting down, there is something going on. It is very likely that he is being triggered. Something has been setting him off, and to be more curious about what that might be. So Jeff, we linked with a therapist, great therapist who meets with him 2 times a month. The therapist also has conversations with Jeff's staff and family. Once a month, he kind of is involved in kind of a multidisciplinary meeting with Jeff's permission. And we did a lot of reviewing of in-home practices by staff, and also when Jeff goes to visit his family, what are some of the practices that are consistent with trauma-informed supports? So he's got a lot of good things going on for him. He is looking at volunteering or having a part-time job. He's requested to have an emotional support dog. He agreed to work with a nutritionist. He has diabetes, and he would like to learn a little bit more about healthful meal planning and participate in that. And he has scheduled regular check-ins with staff because staff cannot assume that because he didn't say anything, that means that nothing is going on, because he is likely to shut down and not communicate. Just a recent example, he actually was hospitalized not long ago for sepsis. And it happened that I guess he has a very high pain threshold because he did not report having any discomfort or pain. And in fact, it was discovered because of behavioral changes that there was very serious, I mean, sepsis, blood poisoning is pretty serious medical condition to be experienced. So fortunately, they were able to get the help that he needed, but it was not, we can't rely on Jeff to tell the staff what's going on and what to do. So, that's, I think, important. And in terms of his behaviors, he will often self-isolate. So that probably means he's feeling overwhelmed. He may not be re-traumatized, but he may be feeling overwhelmed and is lacking the coping skills he needs to manage his stress. And he did have one episode where he got a little overwhelmed and he was with his mother and he slapped his mother again. Again, did not hurt her, but it scared him a little bit. And so he retreated a little bit further. So as I'm saying, this is a work in progress to understand his behavior and its connection to his life experiences and where he is right now. So I'm giving you some resources. There is a very nice, you can download this from the Link Center, Trauma and Trauma-Informed Practices from the ACL Administration for Community Living. And then 2 books by Karen Harvey, Trauma-Informed Behavioral Interventions, and an earlier book, Positive Identity Development, and a classic book by Jay Herman, Trauma and Recovery. So at this point in time, I think I've given you what I have. And so would be really interested in hearing from others about your thoughts, questions, thoughts for the day, that kind of thing.
Thank you so much, Dr. Ezralu. I think we learned a lot in each sphere of our lives, not just for those with adults with intellectual and developmental disabilities. There are a few questions in our Q&A category, as well as one of our hub team members, Dr. Bishop, has her hand up. So I'll let Kathy go first.
Thank you, and sorry to be late. As you know, Catherine and I are in training here up in Denton, Texas, so pleased to be here. Lucy, this is the second time this week I've heard your wonderful presentations. I am always really, always learn so much from you and really appreciate how much you contribute to all of us, so thank you. It also struck me as the part I was able to hear how much this really overlaps into and is also dementia capable care. And
Absolutely.
yeah, and I suspect um, there's a trauma in itself as part of having dementia, having loss, being able to be aware of cognitive loss. And so it just accumulates on top of the life experiences with Jeff, who had never been listened to. I'm hoping you can comment a little more. I have found while we try to train all staff, and I think you're leaving a video for staff and is an excellent way to keep the training going when you can't be there. But things like the dog, a therapy dog, or wanting a cat, can be so difficult for staff. There's always someone who has doesn't believe in pets and doesn't think that's part of their work, or they're allergic to, or it's just overwhelming because they know that a good part of the care is likely it's like a parent who has, and I'm not trying to compare him to a child, but you know, a child who insists on having a pet, and then it's the parents who really become the caregiver. Certainly responsibility to oversee to make sure that that caregiving is going and helping him be able to get food and do the things he'll need to support the dog. So can you comment a little more about getting buy-ins by staff administration? Because there's always changes in the system that have to happen. So could you comment on that, please?
Yeah, well, and this is still in the process, by the way. So Jeff asked for this dog well over a year ago. Um, and as you indicated, there are various levels of bureaucracy that had to be worked through. Reasonable, because all those things that you mentioned, like who is responsible for the dog, and so we've worked out basically, now I'm not actively in this part, but actually his therapist is the one that his current therapist is the one who is more active on this than I am, have a contract that they have developed in which he says that he is going, what his responsibilities are, and staff is to take him shopping. They take him shopping every week for food. And he is going to be purchasing the food. They know where the dog is going to stay. How many times he has, that he has to have a relationship with a vet or, some kind of practice that's in the area, has to make sure the dog gets inoculations, gets to follow up. And this is a gentleman that grew up with pets and animals, so he's very conversant with how to do this. And one of the things I didn't bring out as I'm thinking about it in the presentation is that this is a pretty high functioning guy. And in the course of being in one institute, I mean, he was in institutions for like close to 30 years, right? Between state hospital and maybe a little bit less than 30 years, but 22 years in a developmental center and state hospitals, this kind of thing. His skill set has been eroded, and just being beaten down over time. It's not that he didn't know how to do these things or know how to do these things, just he hasn't had the opportunity and he's become disaccustomed to that level of responsibility and accountability. So there's a whole rebuilding process for him. So there are many reasons why this is therapeutic. So, we did launch a kind of campaign with staff to kind of, and several of whom are themselves pet owners and can appreciate how important a dog could be to an individual. And surprisingly enough, we didn't get as much pushback. Turns out nobody else in the household is, right now, there is only one other person in the group home. And so that other person is not allergic to dogs, I mean, he lucked out in that way. So, your point is well taken. There are many logistics that go into being able to support somebody being able to do this. But I'm pretty confident he's going to be able to have a dog within the next several months. And this will be a game changer for him. So one of the things is that he wants to work. So he's trying part-time, very part-time. So he's trying to figure out what happens while he's at work if he has a dog. And that's right now his problem-solving challenge. Like, what is he going to do? What's his responsibility? So, I mean, okay.
Excellent. Thank you, Lucy.
Lucy, I'm next going to turn us over to Catherine Peters, who has a question and comments as well.
Crate training of the dog is my advice, but at any rate, being a fellow dog lover, I just want to say thank you for a great presentation. But secondly, I wonder if you could talk about the memory regression that occurs with dementia and how those traumatic events that occurred maybe 20, 30, 40, 50 years ago, as that disease process progresses with dementia, oftentimes those long-term memories become much fresher than what you had for lunch today in a person with dementia. And,
Right.
How the impact of that, because I think this trauma-informed care is particularly important for people with dementia, who will relive those traumatic events oftentimes, be they triggered or not even triggered, they just kind of come back. Can you chat about that a little bit?
Yeah, I mean, so, with PTSD, first of all, individuals, so the part of the brain that gets affected by PTSD has everything to do with memory. And, so, it is, and it's impactful on a biological basis. So whether or not the person realizes it or not, it it changes basically brain anatomy or neurochemistry, if you will. Um, there was what I was thinking of as you were asking the question is, and I think it's on the Veterans Administration site, I'm not sure, and their thing on PTSD. There is a picture of an older man looking in the mirror, and what he sees reflected back to him is himself as a soldier in a soldier's uniform when he was obviously a much younger. So what he's perceiving is himself back then when he was a combat soldier and not the older man he is right now, in the staring into the bathroom mirror. I think that that's what happens, with these neurochemical changes. There are, just kind of the saliency of these earlier memories intrude upon the individual. And then if you have dementia, you cannot differentiate. You're not going to be able to say or think, wait a second, that's just my mind playing tricks on me. This is, something that happened decades ago. It's not happening now because your own orientation and confusion and difficulty will make that difficult. So I don't know, when Catherine, when you and I were kind of corresponding about this, I have a question mark in my mind. There are many ways in which Jeff is doing better, many ways, but he's not where he was. There has been an erosion of his cognitive and functional skills. And I don't know if he'll get back to that. And I don't know if he is at risk for dementia because, I mean, he's 58 years old and, and certainly kind of functioning as an much older individual compared to those people who were not with a developmental disorder. So, so a little bit about that and just kind of, people go about their lives. A lot of people have had traumatic exposures or they've had events, stressors that have happened, and they just kind of push on. They just push on.
Yeah.
We have a load of people who were in institutions. They're older now, and they're living in the community and they're living their lives. However, how processed and how kind of attended to was that experience, especially when you've been in an institution for decades and, witnessed all kinds of things. Yeah.
Well,
So,
and I think of it too in the context of things. people who were experienced sexual abuse when they were younger, and then that's PTSD to begin with, but then they develop dementia, and we hear about people having difficulties, combativeness during bathing. Well, what would that maybe mean for that person who's being brought into a room? Someone's
Right.
taking their clothes off,
Taking their clothes off.
you know,
Yeah,
and bringing, and all of a sudden that comes back there, but we label it, well, they're combative during bathing, you
right.
know, as opposed to looking at that under potential underlying cause. This is so
That's a
important.
really, really good. And the other thought I have about it, Catherine, is for people who might not have been sexually abused or physically abused. I mean, most of us as adults, we're used to, these are
Sure.
independent behaviors. And as you become more dependent upon others, and
Yeah,
as you are less capable of doing this, your autonomy is challenged. How vulnerable any of
absolutely.
us can feel and how confused you are, so, the typical person coming into, who with dementia, an IDD, who comes into the bathroom, and the bathroom is an overwhelming place. And all the staff wants to do is give this person a shower.
Yeah.
But everything is so confusing, and the water's coming at them, and they can't kind of distinguish where they are. And so that could be kind of a real stressful situation for this individual. He may not have had a prior history
Right. Right.
of anything, but right now, what they're experiencing is, in a sense, a traumatic exposure because they feel threatened and
Yeah.
overwhelmed in this
Yeah.
situation.
Overstimulated because of the sensory processing challenges that arise with dementia. I've heard a lot of people with dementia say that the sensation of water from a shower on their skin feels like they're being pricked by thousands of tiny needles. And I would
Right,
be combative too, you know, and want to get the heck out of there. So
right,
yeah, I mean, it just shows the complexity of how you have to sort of peel back the layers of the onion to try and figure out what this behavior is communicating, and never just write it off as being combative, manipulative, oppositional, all of those terms that we so frequently, um, you know, attach to these sorts of things, and then want to treat with medication.
right. Which, and again, yeah. So I do think that behavioral approaches which are cognizant of a person's life experience are going to be more, aligned with trauma-informed care, and just what we need to know the person's life story. I mean,
Yeah.
I would have had a very different response to Jeff if I didn't know what I knew about him. Yeah, so it was very, very difficult. Yeah, so that was, and interestingly enough, just as a side, because I do want to get to the two questions that are in the Q&A, is that the way Jeff's mom found out about me and hooked me up into working with him, her, and the team was that she attended a didactic that I did at an ad conference on PTSD. She's like, that's how we did the connect. I was like, so that was just kind of an interesting side. So there are two questions, right? And are some people inherently more resilient? She may answer. Okay. So, the fact of the matter is, yeah, I think that we are born with somewhat different capacities. I also think that our backgrounds make a great deal, have a lot to do with it. How we were nurtured, the kind of protective and compensatory experiences or positive experiences we had when we were younger, our coping skills, and how we develop it. And by the way, so Jeff was really proficient in karate. And one of the reasons he did that was he was so short, and he would kind of get bullied on occasion, but he was a power to be reckoned with in terms of that. And so this is how he compensated and how he dealt with it when he was living in the community. And I thought that was very resilient. And and in a sense, when I hear about all the things that happened to him, I'm amazed he wasn't more battered than he actually was. You know, he did show signs of persistence, resiliency. Even his game plan in kind of getting removed from the environment by doing behaviors that weren't dangerous, but actually sufficient enough to get him away from his perpetrator, because nobody else was helping him. This was the only way he could figure out to do that. I mean, I felt like, all right, well, that was pretty amazing. You know, so yeah, you know, so that gonna have been a comment on about the challenge because of lack of life stories. Yeah, right. Definitely, definitely. Yeah, I mean, you know,
Could you
I
repeat the
think,
question, Lucy, for folks who can't see
oh,
what the
okay.
question was?
So Kathy had written in our class, guardians and other advocates in the class have been commenting over and over again about the challenge because of lack of life stories, knowing anything about each person's medical history or baseline. And that's, you know, I think that's one of the things that happens in our field is that we think what we see in front of us is everything about that person. And that can't possibly be the case. It wouldn't be true for people who without a disability. How could it be the case for a person with a disability who are typically pretty complex? So yeah, any encouragement to get a life story. Um, so there was another question. Do you think the rigidity often associated with ASD would make people on the spectrum more prone to traumatic reactions? Hmm. Probably. I mean, that's my thinking about it, you know. So one of the things about rigidity or lack of cognitive flexibility, which we often see in individuals who are on the spectrum, is maybe the inability to kind of develop coping skills that one needs to adapt to changing circumstances. And many people, not everybody, who is on the spectrum have rules that govern their behavior. Sometimes these rules are pretty idiosyncratic, like it only has to do with that person. And other times it's rules that have to do in general in terms of their sense of fairness and lack of fairness. So not only have I encountered people who've experienced stressors where they have felt they were traumatic experiences, but they've experienced moral injury, which is a term that we kind of use now to talk about when a person's sense of just the deep injustice of what has happened to them. Um, you know, so just as an aside, I used to work on a specialized unit at a hospital that was just an inpatient psychiatric unit for individuals with IDD. And we had a young man who was hospitalized for the first time there on that unit. And that was a traumatized on the spectrum. That was a traumatizing experience for him. Although he was helped while on the unit, just the departure from his usual routine, his ability to kind of make sense of what was going on was a traumatic exposure. And I think that had to do with his cognitive inflexibility with regards to that. So I hope that answers your question. Anything else? Any words for the day?
I want to thank everyone for joining us, particularly, the month of May for me as a mother of school-age kids is very busy. The excitement of end-of-year concerts, recitals, and what are we going to do with our summer, as well as I'm faculty at a university. So those students are scrambling to get out and onto their summer plans. And then all of us are engaged in graduation celebrations and parties. So thank you for making this month a priority. Dr. Ezralu, we really appreciated learning from you and your wisdom that you're sharing with us. A reminder that we meet the third Wednesday of each month. So we're slated to reconvene Wednesday, June 18th. And I think what I'll do is hand it over to Catherine, who can add any more information about that date, and then send us off.
I was afraid you were going to do that, Cameron, because I just drew a total mental blank on what the presentation is for June. But we'll send it out to everybody. So, plan on being with us irregardless. It'll be gripping, whatever it is.
Yeah.
But my mind just went totally sideways on me. But anyway, yeah, we'll send that out. Please, just plan on joining us. We will be here. And I think that third Wednesday is going to be June 18, looks like. So please come back and join us. And as usual, if you have a case that you're struggling with, you don't know how to handle it, you're not sure about resources, by all means, please reach out to myself or to any member of the team, but myself in particular, and let us know. We would love to work with you to present the case for our hub team folks to consider and make recommendations for you and try and help you out with it. So we will send that out along with the recording as a reminder. And with that, I got nothing else.
Thank you, everyone. We'll see you next month.